test. Ideal for academic, clinical, or training use. HLA Antibody Screening test. Detailed explanation. Nub 1. Introduction. The human leukocyte antigen, HLA system, plays a critical role in regulating the body's immune response. During transplantation, the recipient's immune system may identify donor HLAs as foreign and attack the transplanted organ, leading to rejection. To assess this risk, doctors perform an HLA antibody screening test, commonly known as the PRA, Panel Reactive Antibody Test. The PRA test identifies HLA antibodies circulating in the patient's serum, providing insight into how sensitized the immune system is. Sensitization increases the difficulty of finding a compatible donor and raises the likelihood of rejection. Definition. The panel reactive antibody, PRA, is the percentage of HLA antigens in a standardized panel that react positively with the patient's serum. In other words, it quantifies how many different HLA types the patient has antibodies against. No 0% PRA, no detectable antibodies, 100% PRA, antibodies against nearly all tested HLA types. Thus, PRA reflects both breadth and strength of sensitization. The test is often performed using complement-dependent cytotoxicity, CDC method, ELISA-based detection, Luminex single antigen bead assays, most sensitive and commonly used today. Number 3, indications. The PRA test is recommended for A. Organ transplant candidates, kidney transplant recipients, most common, heart, liver, lung, pancreas, or multi-organ candidates. B. Hematopoietic stem cell, bone marrow transplant, pre-transplant antibody evaluation, donor selection, and risk stratification. C. Patients with a history of sensitizing events, prior transplant, multiple blood transfusions, multiple pregnancies. D. Monitoring post-transplant, evaluate development of new donor-specific antibodies, DSAs, assess risk of antibody-mediated rejection, AMR. 4. Use for the PRA test has multiple clinical uses. 1. Assessing sensitization status helps categorize patients into low, moderate, or high risk for rejection. Donor matching. Higher PRA, fewer compatible donors available. 3. Predicting post-transplant outcomes. Patients with high PRA are more likely to experience acute or chronic rejection. 4. Guiding immunotherapy. Used to determine the need for plasmapheresis, IVIG, intravenous immunoglobulin, rituximab or anti-CD20 therapy, desensitization protocols. 5. Listing priority in kidney transplantation. Some organ allocation systems grant higher priority to highly sensitized patients. 5. Why do this test? Need for the test. A. To avoid transplant rejection. If a recipient has preformed antibodies against a donor's HLA antigens, it can cause hyperacute rejection, which occurs within minutes to hours after transplantation. B. To determine compatibility. High PRA reduces the chance of finding a suitable donor. C. To guide pre-transplant treatment. If PRA is high, desensitization therapy may be recommended. D. For transplant waitlist management. Transplant teams use PRA to assess urgency and probability of match. E. To monitor changes in immune sensitization. PRA can increase after pregnancy, blood transfusion, organ biopsy, infections. What happens during the test? Step-by-step procedure. 1. Blood sample collection. A healthcare professional draws blood from a vein, typically the arm. 2. Serum isolation. The blood sample is processed to separate serum, which contains the antibodies. 3. Serum testing against HLA panels. The lab tests the serum against a standardized panel of HLA antigens using methods such as CDC assay, looks for complement-mediated cell death, flow cytometry cross-match, detects binding of antibodies using fluorescent markers, Luminex single antigen bead assay, detects antibodies against specific HLA molecules with high sensitivity. And 4. Calculating PRA percentage. The number of antigens showing reactivity is divided by total antigens tested, giving the PRA score. 5. Reporting results include PRA Class 1, HLA-A, HLA-B, HLA-C, PRA Class 2, HLA-DR, DQ, DP, antibody strength, MFI values if using Luminex. How long for my results? The turnaround time depends on the method. Luminex assay, 24 to 48 hours. CDC method, same day to 24 hours. Extended antibody analysis, 2-5 days. Urgency cases, like transplant offer situations, can be processed rapidly. 8. How to prepare for this test. Generally, no fasting or special preparation is required. However, patients should inform the doctor if they have had recent blood transfusions, recent infections, pregnancy or miscarriage, Recent immunosuppressive drugs, immunomodulating therapies such as rituximab or IVIG, these can affect antibody levels and test accuracy. 99 risks. The procedure involves only blood sampling and is very safe. Possible risks: mild pain at the puncture site, small hematoma, bruise, lightheadedness, rare infection. No long-term risks are associated with the PRA test itself. Number 10, normal values. There is no universal normal, but PRA values are interpreted as follows: 0 to 20% PRA, low sensitization; 21-80% PRA, moderate sensitization; 81 to 100% PRA, high sensitization. Some labs may have specific cutoffs, especially when using MFI, mean fluorescence intensity, values for antibody strength. Interpretation of results. Low PRA, 0-20%, minimal HLA antibodies, high probability of finding a compatible donor, lower risk of rejection. Moderate PRA, 21 to 80%, some sensitization present, matching may be slower, requires careful donor selection. High PRA, 81 to 100%, extensive antibodies, very difficult to find a match, high risk of hyperacute or antibody-mediated rejection, may need desensitization therapy. Class 1 versus Class 2 PRA, Class 1 antibodies, may cause hyperacute rejection. Class 2 antibodies strongly associated with chronic rejection and graft failure. Number 12, factors affecting results. Increased PRA, previous organ transplant, blood transfusions, pregnancy, mother may form antibodies against fetal HLA, viral infections, autoimmune diseases, use of immunostimulatory drugs. Decreased PRA, plasmapheresis or plasma exchange, IVIG therapy, B-cell depleting agents, e.g. rituximab, long-term immunosuppression. Technical factors, testing method sensitivity, serum handling, lab reagent quality. Number 13, clinical significance. The PRA test is clinically crucial for the following reasons. A, predicts transplant success. Higher PRA, higher rejection risk. B, informs donor selection, helps avoid cross-match positive donor candidates. C, guides immunosuppressive therapy. Patients with high PRA may require desensitization, stronger immunosuppression, pre-transplant plasmapheresis. D, helps determine urgency. Highly sensitized patients may receive priority for compatible organs. E, identifies donor-specific antibodies, DSAs, critical in post-transplant monitoring to detect rejection early. No more additional important relay tests and concepts. 1. HLA typing determines exact HLA genes of donor and recipient. 2. Cross-match test, a direct test mixing donor cells with recipient serum to detect reactivity. CDC cross-match, flow cytometric cross-match. 3. Donor-specific antibody, DSA testing, detects antibodies targeting a specific donor's HLA antigens. 4. Virtual cross-match, uses antibodies and HLA data to predict compatibility, reduces time during organ allocation. Number 15. Conclusion. The HLA Antibody Screening, PRA test, is an indispensable tool in modern transplant immunology. It identifies the presence and extent of HLA antibodies in a patient's serum, helping clinicians assess transplant compatibility, predict rejection risk, and plan appropriate treatment strategies. A high PRA indicates increased sensitization and may require special interventions before transplantation. Understanding this test is crucial for both physicians and patients involved in transplant evaluation. Thank you. Have a nice day.